Dear students, welcome back. Now we are going to discuss about the structural dysfunction of the shoulder complex. As we know that the shoulder complex consists of sternoclavicular joint, acromioclavicular joint, glenohumeral joint, and the functional joints or the scapulothoracic joint as well as the suprahumeral joint. So these are the joints present in the shoulder complex. So now we are going to see the structural dysfunction of this entire shoulder complex. Completion of the range of elevation of the arm is dependent on the ability of the glenohumeral, scapulothoracic as well as the sternoclavicular and acromioclavicular joints, each to make the needed contribution. Disruption of any movement, in any of the participating joints will result in loss of range of motion. Once the restrictions to function are introduced, then the concept of scapulohumeral rhythm is no longer relevant, because any reduction in the glenohumeral joint range will not result in a proportional decrease in the scapulothoracic range. The ratio of movement is no longer pertinent, since the body will automatically recruit any and all remaining motions at the other joints. That means if any one joint is affected, the other joints will move more than the normal. So definitely the range of the ratio of the scapulohumeral rhythm are going to change if any one of the joint is affected. Okay. For example, if the motion of the glenohumeral joint is restricted by pain or disease, the total range available to the humerus will be reduced. But the motion on the scapulothoracic joint remains constant. So there is no change in the scapulothoracic region, but at the glenohumeral joint, here the range of GH is going to be reduced, but not the scapulothoracic region. For example, if the glenohumeral joint is restricted at a range of 30 degrees, but along with the scapulothoracic region, scapulothoracic motions, this shoulder complex may show about 60 degrees of abduction. 60 degrees of or total 90 degrees of abduction can be done with the help of scapulothoracic region, but not at the glenohumeral joint. For example, if it is restricted at 60 degrees, glenohumeral joint is restricted at 60 degrees, and with the help of scapulothoracic region 60 degrees, so it will attain the maximum range of motion up to 120 degrees. Okay. That too when the glenohumeral joint is maintained in the medially rotated position. So when the joint, the humerus is maintained in the medially rotated position, then only the range can be increased. Otherwise it can't increase the range of motion if GH joint is restricted due to pain or disease. Okay. And also consider if there is any fusion at the SC joint, will eliminate scapular movement. Because both clavicular elevation and the rotation which is taking place at the SC joint will be affected. So because of this SC joint fusion eliminate both the rotation as well as the elevation which are taking place at the sternoclavicular joint. Okay, movement for the humerus will be available only at the glenohumeral joint but not at the sternoclavicular joint. Okay, and if the coracoclavicular ligament is disrupted, for example, if the coracoclavicular ligament is disrupted, the range of elevation will be dependent on the clavicular elevation and the active glenohumeral motion. So, if the glenohumeral joint, that is the coracoclavicular ligament is disrupted, so what will happen? The rotation of the clavicle does not take place, which is occurring in the longitudinal axis does not take place. Then what will happen? The elevation of the arm can be done by only the elevation of the clavicle and the glenohumeral joint, but not with the rotation of this clavicle. That means phase 2 of the sternoclavicular and acromioclavicular contributions are affected in such cases when the coracoclavicular ligament is disrupted. So these are the dysfunctions. If any one of the structure is affected, the other joints are going to move more than the normal rhythm. Okay, so you can see one example of glenohumeral joint hypomobility. If the motion at the glenohumeral joint is restricted by pain or disease, the total range of motion available to the humerus will be reduced. Whatever portion of the motion remains at the glenohumeral joint will still be accompanied by the scapulothoracic motion. So that thing we can see in the next image. So here in this pic you can see this is the normal glenohumeral motions at the shoulder joint, shoulder complex. So here if you can see this, here we can see this normal scapulohumeral rhythm, but at this side, so at the right side, if you can see, so the abduction is taking place with the help of, see here, with the help of scapulothoracic joint as well as the sternoclavicular joint, that is the elevation of the clavicle and also the scapulothoracic joint. Here you can't get this glenohumeral motions because it is restricted here due to some capsulitis, adhesive capsulitis. This is a case of adhesive capsulitis where the glenohumeral motions are affected due to a restriction in the glenohumeral joint. So this range of elevation is done by the scapulothoracic joint motions as well as the accompanied with the sternoclavicular and acromioclavicular joint. So for that reason only you can see the level of the shoulder during the abduction is at higher level. That means it is elevated. The scapula is elevated at this, in this case. Okay, elevated and also internally rotated, somewhat internally rotated here. But in this case, normal scapulohumeral rhythm can be seen in this left side. So here there is an hiking of the shoulder, It is the elevation of the shoulder is appeared due to the scapular thoracic movements. So this is the glenohumeral joint hypomobility. Whereas in the sternoclavicular joint hypomobility, that is if the sternoclavicular joint is affected, it will minimize the scapulothoracic movement because they are in closed kinematic chain. Whereas in the acromioclavicular, so for at that in that case, there may be an increase in acromioclavicular joint mobility, and also instability is also occurred at the acromioclavicular joint when the sternoclavicular joint fuses. Okay. Normally the hypermobility and instability of the acromioclavicular joint are more common if any fusion of the joint occurs only through surgical fixation, with limited or no acromioclavicular joint mobility within the closed chain of the acromioclavicular, sternoclavicular and the scapulothoracic joint. Motions of the scapula on the thorax could be limited. Okay, that means any limitations of the mobility of all these three joints limits the movements of the scapula. Then only at that time only the GH motions can be seen. Okay, so these are all the structural dysfunctions occur. For example, if the clavicle attempted to protract with a fused acromioclavicular joint, the clavicular protraction would be taking place at the sternoclavicular joint, not at the acromioclavicular joint. So protraction is taking place. Because of that protraction, the scapula would bring into the thorax, and that means the scapula will internally rotated. Once it is internally rotated, the glenoid cavity comes to the anterior surface, which helps in the flexion of the arm. Okay, so that will takes place in the if any acromioclavicular joint is fused. Okay, so this is all about the acromioclavicular joint hypomobility, sternoclavicular joint hypomobility and glenohumeral joint hypomobility. So these are all the structural dysfunctions, and this is a case of adhesive capsulitis where the glenohumeral joint hypomobility is seen. The movements, the elevation of the arm is done by the scapulothoracic joint along with the AC and the sternoclavicular joints, and the GH movement is restricted here. Okay. So this is all about the structural dysfunction which are related to the shoulder complex. Thank you.